Well, it's good to see everyone. This is a great group. When you have to scroll to the second page and you still see people on video, you know that this is a great group. Really excited for our session this evening. We're going to go through just some quick introductions and then a reminder of the program and kind of what's tonight's event and agenda will be. This is informal and it's intended to be a discussion with our FCLC leader scholars tonight and all of you who are joining us. I'm Roy Stroud. I'm a neurologist at Wake Forest and really honored and privileged to help co-lead the FCLC Future Clinician Leader College program. And we'll introduce our program leadership. Tina, maybe I'll turn it over to you.
Awesome. Hi, everybody. This is Christina Nattutag with Tina. I am equally honored to co-lead this program together with Dr. Stroud. And it really is Dr. Stroud's baby. This builds from the work that he has done in Wake Forest Baptist, and we have been able to scale it up at the state level, which I think is just amazing. So this is one of my favorite times to be at these sessions, because I'm so excited to hear these projects and these presentations, and you're going to be, I think, equally impressed by the work that these scholars have done. So
great. I will start just by reminding everyone of this program, and then we'll transition over to our students to lead the presentations. But I did want to just start and say this is just so exciting for everyone to be here. For those of you who are at our North Carolina institutions and have helped support your students to join us for the last year for this program, thank you. This is the best group. Don't tell the other few years that, but this has been a really fun group to work with. And so we appreciate you lending their time and effort to us. For those of you who have spent the last year with us, the students, we're really excited. This is probably the most fun session for us to see, sort of what you've learned and what you've done and to hear from you in an engaging way. And then new this year, we have some 5 practices from around North Carolina. You'll hear that our students partnered and paired with 5 practices and health systems from around the state to tackle a problem. And we cannot thank you enough for joining this effort. You're our guinea pigs. This was the sort of pilot year of seeing how this partnership would go, and we really appreciate your engagement. So Aisha, I'll have you share our intro slides, and let me just run through a couple of things, and then we'll get started. Aisha, does it work? Oh, perfect. Great, so a reminder of the FCLC program. This is a 1-year interprofessional leadership program for students across our health profession training programs in North Carolina. Next slide. And the program this year, last year, and for the next couple of years, it really only exists through our partnership with North Carolina AHEC and Northwest AHEC. And they have funded all of the efforts that you see today and all that we've been able to do over the last year. So great thanks to them. And if you see them or know them, thank them tremendously. Next slide. This program is a statewide program. So the students that you will hear from tonight and the students that we get to work with over the course of the year come from across the state and bring their perspective from health and healthcare and training and patients from many of the training programs across the state, which I think is really exciting and really a unique aspect of this program. Next slide. And the students come together for a 1-year investment in their professional development. And we start with a first workshop on what are your leadership strengths. And for those of you on the session that have done the insights discovery, you'll see the sort of insights leader color wheel, and we go through that in session 1. We move to a session 2 or a series of sessions on, if those are your strengths, how do you lead from that part of the wheel, from that place where you stand and using your strengths. And then we move externally with the last few sessions on team leadership, a series on team leadership and leading in society, looking to translate the conversations we've had at the beginning to leading in your areas of the state and your programs and in society at large. Next slide. This is our third year of the program, and these students are phenomenal. I don't need to tell you that. They come from all of the healthcare professions. You will hear from students who are in DDO training programs, as well as PA, pharmacy, nursing, OT, PT, and dentistry, which is really neat, I think, for us to hear from students from different perspectives, and from them, for the students to contribute from their area of our healthcare professions. Next slide. This is our third year, so this was the first year class that helped to kick this program off, and you will remember many of these folks. In fact, some of them we've invited to the call today. Next slide. Our second year group was here, and we continue to work with some of these folks and have seen them move on to great things. And then next slide. This is the group 2021's class that you'll hear from today, and just a phenomenal group of students that you're going to hear from. Next slide. As a part of the program, the students do a leadership project, and the first year was tackling some problems facing healthcare, like the opioid epidemic, or equity, diversity, cost of healthcare, and a white paper you can see, or a compendium of white papers you can find on our program's website. Next slide. The second year was really leaned into diversity and equity, both related to the pandemic and outside of the pandemic. And here are some of the titles for those white papers that each of our groups of scholars completed last year. And the next slide this year has been a little bit different. So this year, the students partnered with a practice in North Carolina, which is so cool. And again, we thank those practices for doing so, and tackled a problem facing that practice related to community engagement. And so you're going to hear from our 5 groups over the course of the evening. We did a flower theme, which is great, and Tina infused us with those good vibes. And so you're going to hear from the Daffodils that partnered with Centara Medical Center on addressing chronic disease management in the northeast part of the state. You're going to then hear from Team Roses that brought a partnership with Appalachian Mountain Community Health Centers to look at obesity and healthy eating and living in that area, and unique aspects in their community. Then the Peonies that partnered with our constant partner in crime, Katie Lowry, with Robeson Pediatrics. We're really excited about that, looking at obesity in the Robeson County and lessons that we can learn from that group. Then Petunias, partnering with Carter Health, talking about how to tackle smoking cessation and sort of getting patients into the smoking cessation resources in that area. And then our last group is going to focus on dermatology and partner with a practice, with the Pavial dermatology practice, and looking at how to address patient education in their community. So this is the lineup. We're really excited, not only about this year's program, but our presentations tonight. This is informal. So I encourage you who are a part of our program to ask questions of your fellow colleagues and sort of dig into what they learned and how they learned it. Those of you who are joining us, you are on the hot seat too, because we would love to have you engage with those leaders that you know and have sent to the program, and also that are dealing with things that you're facing in your practices. And we hope there is opportunity for good engagement. Each of the groups has about 10 minutes to present, and then 5 or so minutes for discussion. So we have ample time for questions and those sorts of things. So write them down or put them in the chat, and there's ample time for that. So with that, we're going to kick off with our first group, but let me just pause and see, Tina, Aisha, any other things we need to announce or do before we get started?
I think we're good to go.
Great. All right, Team Daffodils, we will turn it over to you.
All righty. Can everybody hear me okay? We're Team Daffodils, comprised of Allie, Kate, Manuel, Trandon, Meredith, and myself. And our topic is addressing chronic disease management and barriers to healthcare access in the communities served by Centara Albemarle Medical Center. So the practice that we partner with is actually a large hospital. Centara Albemarle is a 182-bed hospital in Elizabeth City, North Carolina. It's part of a larger system of Centara healthcare networks that serve multiple locations in Virginia and northeastern North Carolina. The demographic that Centara Albemarle primarily serves is in Currituck, Camden, Pasquotank, Perquimans, and Gates counties. We did a little map here so you can kind of see the surrounding areas around the hospital. Serves about 123,000 people, and the entire service area is primarily rural.
Okay, so I'll take over. Thank you, Kay. So our main objective with this study, or how we got started, was we used the Centara Albemarle Medical Center, the healthcare needs assessment of 2019. It was a really great resource for us to use. And our advisor, Dr. Bowling, was really great in providing that for us. It really gave us a really good idea of the needs of this area, which gave us a really good helped us to identify where we can make the best impact with this project and in these communities. The main problems that we addressed or found from that were lifestyle and healthy behaviors, access to healthcare, and then the third was chronic disease management, including mental health.
All right, and for our solutions that we wanted to use to address these problems that Meredith just talked about. So one, we wanted to address lifestyle and health behaviors in the community and improve access to healthcare. And we wanted to accomplish this by not only increasing connections with fellow community stakeholders. So we created handouts, which you'll see in a few slides, that had specific community resources of all the counties that were previously discussed. And we wanted to include resources, including food and shelter and overall wellness in each of these key areas. And then secondly, we wanted to increase preventive care and cancer screening. So we also made a brochure outlining specific screenings and timeframes that are the suggested screening intervals for these various disease managements.
And so here's the first of two resource handouts that we've created for patients and members of the community to improve their awareness of the resources available, as well as the next slide, which will cover when certain healthcare screening should be performed. So community resources here, and it just kind of breaks it down as for general wellness, healthcare management, and then more community resources, tackling food insecurity, housing insecurity, and just general areas that can help you get access to more wellness facilities. And we included an internet resource as well as a phone resource, and just to try to give somewhere where they can just either call or go online to get more resources, more information. And then this is the health screenings handout. And this just really breaks it down by general wellness for men, women over the age of 20, and kind of break it down by cholesterol, general physical exam, colonoscopies, and then break it down by women and men specific screenings. This is something that we tried to kind of create it where it's easy to kind of read and is a very approachable health screenings handout, and something that if you are a third-year medical student, you can easily use, or any other healthcare student you can also use.
So something that was pretty cool is that our brochures are already in use by social workers at Centara Albemarle. So it was pretty cool to see how quickly we're like already making an impact in the local communities. And then Dr. Bowling, he said that this allows the integrated care managers to give patients an easy to read resource. And sometimes it is hard to find out where your resources are, but the fact that they are all in a single place, and like you can even call or get on the website to find additional resources is something that I think is very helpful. And we are hoping that this makes an lasting impact in these communities.
And so in conclusion, Centaurus Medical Center, like other underserved regions in our country, has some difficulty with connecting its students to all the healthcare resources that are available. A lot of times there are a bunch of resources that are available, but the difficulty is making sure that patients are aware of them and how they can access them given the different barriers that they face. So we pretty much took the health needs assessment and just identified different areas with Dr. Bowling that we could best connect patients to different resources. And we did this through the brochures. We only listed one brochure there, but we separated them out into every single county. And this way it gives it an easier way for patients that are residing in those different areas to see what's available near them and ways that they can get in contact with the different resources. And then ultimately with our preventative health handout, we're hoping to practice more preventative health medicine rather than reactive. Chronic diseases are obviously something that affects a lot of our country. And so if we can try and prevent some of these different diseases, such as cancers with screening and diabetes and different things like that, the ultimate goal is to prevent them from even occurring in the first place before we have stepped towards treating these. And so next slide, please. Can you go to the next slide? Our last slide was just
It's frozen.
okay. Our last slide was just an acknowledgement slide, and just wanted to say a big thank you to the rest of my team. Daffodils have been awesome to work with this past year. Glad we all got to climb Mount Everest together and have been through a lot. So appreciate the help from all my teammates. And then to Dr. Bowling, thank you for offering your time to us. I know you're very busy, and so we really appreciated all the feedback and guidance that you gave our team. To Dr. Stroud, Tina, and Aisha, and the rest of the administration at the FCLC, thank you so much for your guidance throughout this past year. It's been such a joy hearing the different speakers that we've had come to our different sessions, and it's been a great experience, so thank you.
Fantastic, great job. Great presentation. A lot of claps and things. Well, we'll open this up to questions or comments from anyone. I know Dr. Bowling is on, but I don't know if available, or if you have, Dr. Bowling, any comments or thoughts on how you've seen this in the practice.
Well, as they stated, the resources guide that they created has already been distributed through our integrated care managers to patients that might have trouble connecting with resources in the community. I do like the 211 because you can't list everything on that form, but that's a new resource for our area that's just launched in the last 2 or 3 years. So having that on there brings awareness to that. I guess I do have a question for the group that I didn't get to ask. And what resources did you use to determine the guidelines for screening?
So I think earlier on, you sent us a large document with, it was really like a breakdown of health disparities in the different counties that the hospital serves. And it kind of broke it down demographically, how many people develop cancers of various types, how many develop colon cancer or otherwise, breast cancer, how many have diabetes, high blood pressure, so we tried to tackle, tried to consolidate all that information and tackle the ones that we felt are not necessarily easy fixes, but if they were on some kind of document that just people were told, if you are in this age group and you have not had this screening yet, go see your doctor. And we felt that those things like cancer screenings, blood pressure screenings, even something like dental screenings, those would be things that are very easily tackled by putting them in this kind of document.
Okay, so that tells me how you selected which ones we're going to focus on, but I'll make it multiple choice. Is it based on U.S. Preventive Services Task Force or American Board of Internal Medicine, American Board of Family Medicine?
I see what you're asking. So this is USPTF guidelines.
Okay.
Yes.
Fantastic. Other questions for the group? And maybe while you're thinking, if you want, it's given that we have so many people, if you have a question, if you would raise your hand. Quincy, perfect, well done. And I'll save my question, Quincy. I'll let you go ahead.
Awesome. You all did such a wonderful job with this project, and I really love the idea of giving resources, particularly to the populations that need it most. One of the things I wondered is kind of as like time progresses, did you have a recommendation for how you keep those resources updated, or who kind of owns that responsibility?
Yeah, that was one thing I think that we are gonna hopefully still be in communication with Dr. Bowling about. But that's one of the reasons why we wanted to make sure to include the 211 and the NC Care 360 information at the bottom, because these resources like food pantries are amazing when we have them, but are something that are in constant fluctuation. So we put the contact information for all of those pantries that are currently available, but really hoping to encourage people to use those resources to not only find food and shelter, but other resources in their community. But hopefully we can collaborate with the clinic to identify someone to maybe update this, whether that's like Q6 months or every year, just to make sure they're up to date for our patients.
Great question. Dr. Greenblatt, good to see you.
Hey, congratulations, Daffodils, on a really nice project, and for taking on some of the really very hard stuff of population health and primary care. I'm wondering, was your experience that the folks in the counties that you were working with, did you get the sense that lack of insurance coverage for a lot of these preventive services was a significant barrier? And if so, would Medicaid expansion have been something particularly meaningful in the counties where you were?
Yeah, insurance.
Go on, Allie.
Oh, I was going to say insurance status, I think, is something that always comes up in the community health needs assessments across the state. And I think Dr. Bowling can particularly speak to this and how that impacts his patients. But I do think Medicaid expansion could make a big difference in these communities by increasing insurance coverage and ideally improving access to these various screenings.
So I'll tell you that we do have a very poor payer mix in our region, a lot of retirees, a lot of uninsured. And so Medicaid expansion is definitely something that we're lobbying with the NCHA. I'm part of the HOSPAC committee and part of the regional policy committee. So we are in great support. We just don't like the current bill that's out there because it has other punitive stuff in it against hospitals, but we definitely want Medicaid expansion.
Great question. Thanks for raising that. Dr. Capola, maybe the last question for this group. Thanks for asking.
Yes, excellent project. This is exactly what should be happening to improve population health. I was wondering about whether or not literacy was an issue, because I've been shocked in my own practice about some patients who just have difficulty reading. And I think your pamphlet was excellent, but was literacy something that was thought about? And, if so, how did you address that?
Yeah, that's a tough question. I can't say that we have an exact idea about literacy in that area. I think that it's a problem no matter where you go. And I think that it's really important that you curate resources that are accessible to everybody. I can speak specifically to our resource sheet, our community resource with the counties, that we did make a very conscious effort to keep language simplified and make it accessible and use kind of information that they would need in order to get involved in these services, who to contact, whether or not they need to pay a fee, things that are important to patients reading those resources. So it was something we thought about, although maybe on a less precise scale.
Thank you.
Yeah, great job. Health literacy may come up later too, so we can also ask that question against some of our other groups. Thank you, Daffodils. Great presentation. Great job. Thanks for your hard work. We will move to our next group, Team Roses, which brings us a project in partnership with Appalachian Mountain Community Health. So we'll turn it over to you all to share your screen or your presentation. I know we see some people on from this group. Do you all want us to help with sharing your slides?
Yeah, just having some technical difficulty getting it to allow me
No problem.
to share it.
And Lauren, if it's not working, we can also share it.
Can you guys see my screen?
Madison, we can see it.
Beautiful.
Great.
And I'm on it. If I can make it big.
Yeah, you could try that where it says slide up there. See if you were right next to it. Yeah, next to format. See if that works. Oh, maybe not.
Madison up next.
There you go. Yep.
All right.
That's perfect. Good job. Great.
Hi, everybody. My name's Cecily, and we did a project focusing on providing access to and resources for the implementation of the Mid-South diet to provide healthy dietary options to help improve metabolic parameters. Lauren, Ankita, Madison, and Sean all did phenomenal work on this project, and we're really excited to tell you about it. So we partnered with Appalachian Community Health Centers. I have had a relationship with this clinic. I work very closely with one of the clinical pharmacist practitioners there. There are several clinics among Buncombe, Cherokee, Jackson, and Graham County that provide a variety of different services, including primary care, behavioral health, pediatrics, pharmacy, medication assistance therapy, physical therapy, chronic disease management, and they provide this to an entire variety of patients. They accept Medicare, Medicaid, uninsured patients. They offer a sliding scale for patients that don't have insurance for what they're able to pay, but if they are not able to pay anything, they don't ever deny care and they'll see anybody and they won't keep a bill that will keep them from being seen. They provide lots of pricing discounts for medications and then a lot of medication assistance with helping patients get a hold of those medications. The team there is various providers, clinical pharmacists, practitioners, NPs, PAs, MDs, DOs, social work, community health workers, peer support specialists that help a lot with the addiction recovery there. And we worked specifically with the Dale Fell Center that is in downtown Asheville that primarily serves a lot of Medicare, Medicaid, and uninsured homeless patients.
So we had a couple of back and forth conversations with the center deciding how we were actually going to come up with an idea of a resource to help them. So originally it was kind of this discussion around obesity and how are we going to fix obesity in the Asheville area, which we obviously know this is a multifactorial problem and it's likely too large of a task for us to be able to pinpoint something to improve obesity itself. So through talks with them, we kind of identified that there's a lot of food deserts in the area. Asheville has a high rate of poverty and homelessness. I think a lot of people are familiar with the homelessness crisis in Asheville, and those being just a few of the social determinants of health that contribute to kind of this increased rate of metabolic disease in the area. So the center itself had already received a UNC grant, essentially implementing the Mediterranean diet in the primary care office for 8 months and then tracking cardiovascular outcomes. They were providing teaching to patients. They were giving them handouts or essentially information on what the Mediterranean diet is. They already had a lot of recipes and things like that. But their problem was that essentially they have limited access. Their patients have limited access to them. And so how can we fix that? And so we were essentially charged with creating resources for low-cost food pantries, transportation database to serve patients. So providing patients with like the bus route of the local area, where can they go to actually get low cost or free food to be able to actually implement this diet. And so briefly, if some people might already know what metabolic syndrome is, but it's essentially a cluster of conditions or risk factors that increase the likelihood of having heart disease, stroke, and type 2 diabetes. These are just the criteria that I put on, and you can read that at your own pace, but you essentially need 3 or more of the ones that are listed here on the slide. And then we know about 1 in 3 adults actually have metabolic syndrome, and this is largely preventable with lifestyle modifications.
So here's a little bit about what the Mediterranean diet is. So it's based on the traditional foods that people used to consume in countries bordering the Mediterranean Sea. And it's been proven before in research to significantly reduce cardiovascular disease and overall mortality. If you look at the graphic on the left, you can kind of get an idea of what foods are incorporated in the Mediterranean diet and at what frequency. So every day you can have vegetables, fruits, whole wheat, grains, olive oil, and things like that. On an often basis, you could have fish and seafood. Weekly could be poultry, eggs, cheese, and yogurt. And then less often could be meats and sweets. So that's a little bit about how to follow it. So the Mediterranean diet, like I said, has been proven to be successful in showing both the development and slowing both the development and the progression of chronic illness. And they did try to incorporate this before a little bit, like we talked about, but there was a lack of resources and transportation options for the patients. So it wasn't fully implemented. So that's kind of where we came in to decrease the amount of barriers to access resources. And that's what we focused on in our project.
Okay, so a little bit about the Asheville area that we were working with. So the population itself is around 92,000, and 13.3% of that is below the poverty line. So when we're looking at our country as a whole, we're around 11.4. So they're doing worse off in Asheville. Similarly, out of that 92-ish thousand, 527 people are qualified as unsheltered, and that comes from the End Homelessness Project. And that is way above what it is nationwide, as you can see. And then you have 10% of our nation is showing food insecurity and 15.4 in Asheville. So this clinic is trying to work on a Mediterranean or diets to help their health, but a lot of these patients are struggling to find food at all. So this was a big task for us. So let's see if I can get to the next one. Okay, so a little bit about food insecurity. So the USDA defines it as an economic and social condition of limited or uncertain access to food. So I think we've all kind of heard about food insecurity in general. Something that we learned more about on our research is that there are classifications under that of low food insecurity and very low. So low food insecurity is when you are struggling with different options. So your variety is decreased with the foods that you have in front of you. And very low is when it's not even totally about the variety, but you maybe are not having enough food at all. So that's when your eating patterns are changing, you're skipping meals, you're rationing your food. So those are terms to be familiar with. So a lot of the things that can play a role in that are these patients' economic stability. So do you have the money to pay for these food options, or do you have the money for the transportation, which, as we said, is a huge aspect here. So the bus system in Asheville, they run 18 lines all around the greater area. But even when researching and trying to make our resources for them, it states that any day the routes might change or different routes might be available. So if you're trying to be someone who's trying to have a regular routine, or you are just need to get in a rhythm of getting your food from a certain place or going to these medical appointments, that inconsistent transportation option is not going to be good for your health. So this is something that can lead to you developing illnesses that could have been preventable, but also with people who already have diagnoses that they could absolutely and do get worse.
All right, so as we've already heard a lot of great information about a lot of the problems that this specific area faces, here's a slide that goes into more detail about our proposed solutions. So what we did is we developed a comprehensive list of food pantries that also coexist with the most efficient public transportation options to each location. There was a total of 45 in Buncombe County. More specifically, 28 of those were in the city of Asheville. So overall, our written resource aims to direct patients towards the most affordable and easily accessible ingredients that align with the Mediterranean diet, as we had talked about before. And more specifically, we actually were able to illuminate areas that were deserted by the transportation system.
In Madison, if you're able to, are you able to pick up the MANA reference on here and show it by any chance?
Let's see.
This is, we're just showing you the reference list essentially for the area. It services not only Asheville, but the entire kind of Western North Carolina area. Actually, for whoever's out there, this is the MANA Food Bank and public food pantries. And if you continue to scroll, you can see that there are literally hundreds on here. But like we said, 45 specifically in Buncombe County and 28 of those being in Asheville, where our patient population is. Thanks, Madison.
Yes, ma'am.
So the clinic itself had gotten this grant to implement this diet within their patient population, and they distributed a big resource, or they're going to. This project is scheduled to start in July. That contains a little bit about metabolic syndrome, some of the research that's behind it, and as patient-friendly terms, to explain why they're doing it, with the food insecurity that's in Asheville. And going to some of these food banks, you can't always pick and choose what you're going to get there. So they included it's called the Med-South Cookbook. So it's the Mediterranean diet adapted to Southern cuisine, to help with what you can find in this area, because our local grocery stores are the Ingles or Food Lion, and they're not necessarily the most comprehensive in everything that they offer. They are very limited in the options that you have at that store. And so within what they can accept with SNAP and EBT, which is also part of what we looked at with these grocery stores, how patients can supplement what they are getting at the food banks with ingredients from the grocery stores to adhere to this diet as best as possible. And they are meeting with counselors every few weeks and getting metabolic panels every few months to kind of track how this is going in there. And so what we did was we created the resource for patients to be able to meet with these counselors, for those that have like lower literacy, to go over the bus lines that they can take to get to these grocery stores, and help them sign up for SNAP and EBT for the ones that do accept it, for those that may not have already signed up for that. And then in addition, putting together a list that the clinic can then manage and edit as things fall off, things get added, to help going forward when this project is over, for them to still have a database that they can access to help with their patients and their food insecurity. And so that's a little bit of what our project did. Dr. Taylor couldn't be here today. She's a very, very busy lady, but she has looked over all this. She's very excited about all of it. The clinic itself is really excited to have this resource to be able to hand out to patients going forward, not just for this Mediterranean diet, but to have a list of transportation with available food banks and grocery stores that accept SNAP and EBT around here, because not everyone in Asheville does. There are a lot of little grocery stores that don't accept it. But to have something like that they can use going forward to help with their patient population. And that's it.
Fantastic. Thank you, Team Roses. Great presentation, and gave us a lot of stuff to think about. Great resource. Reminder of how important information is, but only if it's in a way that can be used. And so great presentation. We have time for maybe one or two questions. And so if you have a question for this group, I will encourage you to raise your hand. A lot of great jobs in the chat. We have time for maybe, yeah, Sarah Garbick.
Hey everyone, great job. Thanks for sharing. My question is actually just on one small detail that you mentioned about the combination of the food pantry and using like the grocery store to create the Mediterranean diet, which I thought was really interesting. Were you able to sort of come up with a list that you could hand any of the persons who may be going through the program of, this is what you can expect through the food pantry, and these are things we may be able to, we may suggest that you look for alternatively? Was that something that this group looked into?
That's not necessarily something we looked into, but that is something Dr. Taylor addressed with us when we were going through all of our questions with her. That especially in Western North Carolina, given like how many healthcare deserts there are and grocery deserts and food deserts, that the food banks here are maybe a little more unreliable than some in other areas, especially with like donated food and that. So I think from our understanding of what they are giving the patients going forward is like more of the shelf staples that you can get at the grocery store and like at the food pantries, and the vegetables, fresh meats, fruits, and other like perishable items that you can get at the grocery stores or some of the community gardens here.
Fantastic. Dr. Greenblatt, I see your hand, but I also saw Dr. Petrovic, your hand up. Maybe false alarm.
No, I was just trying to clap.
Oh, excellent. Well, thank you for clapping. Great. Thank you. Dr. Greenblatt, let's go to your question.
Thank you, though.
Oh, Larry, you're muted.
Oh, yeah, I was just saying, feel free to not call on me if others have questions, because you'll hear a lot from me tonight. That's who I am. That's a terrific presentation. And I love how you guys linked a condition that I think many might think of as being one of overnutrition, right? Metabolic syndrome. These are people that have obesity, big bellies, they're heading towards diabetes and et cetera. But really what's behind it for a lot of folks is that their food budgets are so limited, they don't get to choose the healthy foods that really they might want to choose, but just are outside of what they can afford. So anyway, I think that's great thinking, and I love how you made this super practical. I love the Med South diet. I'm going to have to find that and then recommend that. I was going to also throw out, there's a woman, I heard her interviewed on NPR years ago. She was in her master's program in nutrition and wanted to write a cookbook on she called it Good and Cheap. And I'm going to put a link to her website, and on there is her book, which is in English and Spanish. It's basically like cooking on $4 a day. It's not really Mediterranean diet. It's like the nutrition was a little bit secondary to like palatable and low cost, but pretty reasonable choices in there too. And I love the idea that you empowered people, like, here's what we have, here's how you can help yourself, and, not just, like kind of a finger wag and you need to do better, which I think has been the traditional approach of medicine when it comes to this kind of thing.
Yeah, great point. And Dr. Caprillian's going to look up Med-South too. I saw this in the chat. So you've got us all Googling, this Med-South.
I actually do have a copy of the cookbook that they're distributing, and she did give me permission to share it. If anyone's interested, I can put my personal email in the chat, and if anybody wants it, I'm happy to send it out.
Oh, you're going to get 48 emails, Cecily, so be careful. Fantastic. Well, great job, group. Fantastic presentation, and thank you so much. All right, in the interest of time, we are going to keep going. And our next group is Team Peonies with Robeson Pediatrics. And so we will turn it over to you all to share and present.
Sorry, it looks like I'm also going to have issues sharing this.
No worry, Caroline. We can help you with that, I think. Aisha, do we have their slides? Do you think we could help?
Yeah, let me see if I can open it up as well. We're having thunderstorms over here too. All right, I'm going to share my screen. I have it open here.
Thanks, Aisha.
Mm-hmm. Are you able to see it?
Looks great.
Okay. All right.
All right. Well, before we begin, I just want to say I've been very impressed with each team that's come before, and I could not think of a better team to follow than the Roses. So our project is facing childhood obesity with our community care partner being Robeson Pediatrics, specifically Dr. Lowry. We figured we'd take a brief moment to introduce ourselves as a team. My name is William Eccles. I'm a fourth-year Campbell Medical student.
And I'm Akil Adlan. I'm a fourth-year Campbell Medical student.
I'm Liara Barrett, a fourth-year pharmacy student at High Point University.
I'm Emily Campbell. I'm a second-year PA student at Duke University.
I am Sarah Carpenter, a second-year graduating student from Western Carolina in a nurse practitioner program.
And I'm Caroline Hall, a second-year PA student at Gardner-Webb University.
Next slide. So the matter in question is childhood obesity. Childhood obesity has tripled in the past 3 years, 3 decades since the start of the COVID-19 pandemic. Even the rates have nearly doubled. So this is obviously an impacting problem in the pediatric population. This is particularly evident in Robeson County, where Dr. Lowry, our partner, practices. Children's educations were not the only thing affected during the COVID-19 pandemic with outbreaks. As children were shifted from in-person to remote learning and then back again, their access to nutritional and regulated school-based meal programs were interrupted on a regular basis. So in addition to their diet, school-provided physical activity was also interrupted. And this can be impacted not just because they weren't in the classroom, but they also weren't having organized play outside and potentially organized sports after school. So our team has come to understand that childhood obesity is a multifactorial disease, and we decided to create a multifactorial approach to address this issue. So Emily will now go into more of the details about the factors leading into childhood obesity. Next slide.
All right, thank you, Sarah. So numerous factors contribute to the development of childhood obesity. Some of these factors include diet, physical activity, genetics, socioeconomic status, physical environment, social networks, illness, medications, and accessibility of recreational facilities, and affordable healthy foods. As you can see in this diagram, it is definitely a multifactorial issue. Next slide, please. So childhood obesity not only has immediate negative impacts on a child's health, but can also negatively impact their long-term health as an adult. Studies have found that children who are overweight or obese are more likely to suffer from psychological stress, such as lower self-esteem, depression, and anxiety. Children who are obese are more likely to become obese adults when compared to their normal weight peers. And research has shown that obese children are more likely to develop serious medical conditions as adults, including type 2 diabetes, high blood pressure, liver disease, and bone or joint-related illnesses. Next slide, please.
So as I said earlier, I am a fourth-year Campbell Medical student, but what I intentionally failed to mention is that I am doing my rotations through UNC Southeastern in Lumberton, which is the county seat of Robeson County. I love to brag about my past year in Lumberton. I think Robeson County is truly a unique place. It is one of the largest counties in North Carolina by landmass, and it is one of the 10% of counties in the US that is considered to be majority minority. It is home to the Lumbee Indian tribe out of Pembroke. So I think before we kind of delve into our approach to addressing pediatric obesity, we needed to understand the demographics of the county in which we were working. So kind of some financial statistics from 2019 is that 31.5% of Robeson County lived 100% below or at the federal poverty level. The median household income was $34,000. And in 2015, 39.5% of the population was considered obese compared to a state percentage of 29%. Next slide.
So as we pointed out, obesity has many factors that contribute to its development, but two modifiable risk factors that we targeted with our project were physical activity and diet. So there are many reasons that people may find it difficult to adhere to proper diet and exercise, but as Will highlighted with those statistics that you just saw, financial stress is a big concern in Robeson County, which make healthy food options difficult to obtain. And so as far as the physical activity portion, we did research and we looked, and it's found that group activity is found to increase participation in physical activity. And in general, physical activity is known to reduce the risk of chronic diseases such as diabetes and cardiovascular conditions. So this really ties into what we did with our proposed solutions with this project. So Akil will get into how we use this knowledge to form our solutions.
All right, next slide, please. Thank you. So as my teammates have stated, obesity is really a several factor disease, and it can be either poor diet, lack of exercise, genetics, and Robeson County itself had some very unique demographics that we had to account for. Plus, given the time constraints of the project, we quickly realized, just like other teams that have gone before us, that it was not possible to address all of these factors with a single project. Instead, we started by listening to Dr. Lowry and her insights into the community. Even with our time and resource constraints, we wanted to do something that had three things. One, something that had meaningful impact. Two, create something that would be sustainable. And three, something that is scalable. So we focused, as Liara mentioned, on two particular areas. One is physical activity, and two is diet. First, we partnered with Girls on the Run, which was established many, many years ago with the mission to strengthen physical activity in grades 3 through 8. And because of the rural nature of Robeson County, a vast majority of recreation occurs either through schools or through county-sponsored recreation leagues. Robeson County, if you've ever been there, is really a desert for recreation exercise programs, such as Girls on the Run. And most recently, Girls on the Run has partnered with the YMCA of Southeastern North Carolina, which is in Robeson. And this partnership will allow us to bring that program to Robeson County completely. So first, what we want to do is bring that to the county by giving the opportunity for the pediatrics patient at Dr. Lowry's office a chance to join this program and slowly scale up by expanding it to nearby schools so they can recruit participants. We've also addressed the funding portion of the program through Dr. Lowry, who has mentioned that she has connections through the Kiwanis Club to provide support so people can be recruited and gone into the program. Secondly, as the saying goes, we are what we eat. And given the poverty in the county, many people are forced to work multiple jobs, and access to fresh foods is very limited in Robeson. So people are pushed towards unhealthier options because of lack of time and lack of resources. So we thought if we can provide an avenue for people to make better decisions, people will make them. So we decided to design things called meal plans, and we wanted to convince people that meals can be affordable, delicious, and can be in a very simple prep time of under 30 minutes. Next slide, please. So we made meal cards that could be given at each pediatric discharge. We were very intentional with our design, focusing specifically on time, which is listed right at the bottom in very heavy letters, cost, which is right in the middle in the bottom, and simplicity, emphasizing that all these meals would cost less than $5 a serving and would take less than 30 minutes of prep. And all of these ingredients would be found in local retailers within Robeson County. So through physical activity opportunities for kids, as well as changing meal habits, that's how we focused on our efforts to solve a portion of obesity in pediatrics. And Caroline will finish out the rest of the presentation.
Next slide, please. In conclusion, we found one approach to address childhood obesity would be activity and nutritious food affordability for not only children, but their families. So we thought it'd be good to keep the prices under $6 so they can compete with fast food options. And we also thought it'd be important to provide tools to address patient barriers and family barriers to actually get better food options and have activities such as joining Girls on the Run and having it funded through a program like Kiwanis Club. And we think group activities such as Girls on the Run and the neighboring program Stride, which is for males, could also be a great way to get children engaged in activity, as we've seen that group activity increases activity overall. Additionally, we found from working with Dr. Lowry that a passionate and active community member really can make a difference. Individually, what we learned through this as a team is building our individual and team leadership skills. We learned how to develop flexibility as leaders, and we saw the efficacy of different leading styles as we all work together. And then we can see that there is an important reminder that the future of healthcare in North Carolina and beyond requires teams of different backgrounds and experiences to really come together to make change. Next slide, please. And we would like to thank Dr. Lowry of Robeson Pediatrics and then welcome any questions you may have.
Fantastic. Wow, great presentation. It's inspiring to see a group that was inspired by, a great physician, Dr. Lowry. There's a lot of questions, and we'll try and get to those. Looking at time, Dr. Peters, maybe we'll start with you.
Hi, thank you for your important work on this hugely important topic. Just wondering if there are any costs associated with Girls on the Run participation, or maybe thoughts on how to minimize those costs to these kids. It's just and again, it's just such an important topic.
Thank you for your question, Dr. Peters. So Girls on the Run is an organization throughout the nation, but there are different areas in North Carolina. So a representative will cover a certain region, and the representative that covers the southeastern North Carolina area, she has a relationship and is funded partly by the YMCA of that area. So she is eligible to provide scholarships through the YMCA to students. And some teams are able to cover the $75 fee through fundraising. Some teams are eligible to cover it through scholarships that their parents fill out a one-page application and submit it to the YMCA. Or other teams, like the one that will be developed in Robeson County, can apply for community scholarships. The Kiwanis Club sponsors children in particular, and most clubs usually give about $300 per child for such an event. So more than covered.
Fantastic. Sarah, I see you put something in the chat. Do you mind giving us a little bit of details about that? That's interesting.
Yeah, sure. I've been involved with Boone. It's called High Country Girls on the Run for several years. And we basically have a board for the local group, and we do several different fundraisers. Many of them are local running races. We do fundraisers through silent auctions, in-person auctions, dinners. And most of the coaches are volunteers who have some sort of interest in a health or background. Mostly we use Appalachian State students who have, exercise science, something like that. And so it sort of feeds itself. It's a really fantastic program.
Fantastic. Thanks for sharing, Sarah. I thought I saw one more hand for this group. Any other questions for our Robus and Pediatrics group? Dr. Capola. Oh, you're muted.
Oh,
There
thank
you
you. All right, another excellent presentation. One other issue that I thought about it when talking about dietary counseling is target caloric intake and target portion size, which is very easy to lose sight of with how we eat in America. Did you take that into account in kind of making health information, dietary information accessible to your patients?
Yes, sir. So we used other meal plans to look at it, and we portioned it in terms of looking at carbs as well as protein intake as calories.
Okay. All right. Very good. Thank you.
I think one of the more important parts of when we were making kind of the meal plan was making it under $6 in order to compete with the local fast food options, as well as really focusing on the caloric intake. And obviously with children, we know that they have expanding caloric intakes based off of growth. But we wanted to kind of focus on something that would be easy for them to do, whether or not a parental figure was home. So we really wanted to focus on kind of a global aspect of that.
All right. Very good. Thank you.
Fantastic. Well, great presentation. It was neat to see how you all focus on the kids, but also recognize the importance of the families. And it's just such an important part of that intervention. So thank you all. Great presentation. We appreciate that. And we will move to our next group, which is the Petunias, partnering with Carteret Health. So we'll turn it over to the Petunias. If you all want to share slides, great.
Yeah.
Okay.
Sorry to interrupt you, Dr. Stroud.
No worries.
Can y'all see my slides?
We can see it.
Okay, well, I'm not starting.
That's perfect.
So we are a group for the Petunias consisting of Reagan, Alex, myself, Allie, Austin, and Logan. And our project focuses on smoking cessation at Carteret Health. So we did a little bit of research on smoking prevalence, and we found that it's increased in rural areas compared to urban areas. And then to go one step further, we also found that efforts to increase smoking cessation in urban areas is slightly effective. However, research shows that there's very little efficacy in rural areas. So we partnered with Carteret Health, who found this problem in their own patient population. And by talking with Brandon Cardney, we found that a lot of patients express interest for smoking cessation. And so the institution sets up appointments for that. However, patients don't attend these appointments that are set up. So for this project, we really wanted to focus on why patients smoke in a rural population. That's novel and hasn't been shown in other research. And then we also, primarily for this health system, wanted to discover why patients weren't attending appointments for smoking cessation when they expressed interest, and see if we could discover any barriers. And then ultimately, we wanted to use this information to provide some solutions to target the barriers so that patients could ultimately get the care that they needed.
So we did a brief literature review just to familiarize ourselves. We all know what smoking cessation is, but we just wanted to see what was out there in terms of methods used and what was effective and not effective. So in some of the articles we researched, we discovered the priority populations for that should be targeted for smoking cessation should be those with cardiovascular disease as well as pregnant women. The majority of the articles discussing smoking cessation sought to define and discuss various methods and attempts, which include pharmacological and non-pharmacological therapies. Some of the pharmacological therapies that we're familiar with include bupropion and nicotine replacement therapies. Non-pharmacological attempts include acupuncture. And one of the articles titled this as the sheer will method, which is very interesting. Basically, it's going cold turkey. And there were also a couple of programs highlighted in some articles that provided incentives for quitting. And they kind of highlighted what that was like and how effective or not effective those programs were. Overall, there was a lack of recent evidence-based articles related to smoking cessation in more poorer, less advantaged socioeconomical regions in the United States. So kind of really supported our need for a project like this.
All right. Hi, everyone. My name is Logan, and I just wanted to share a personal experience where the whole idea of smoking cessation kind of has not only a physical, but also a social impact. Not necessarily on myself. I grew up with my grandparents. They had been smoking since they were 12 and 13 years of age. And so them being in their 70s when I was growing up with them, I knew they always felt bad about smoking around me. I would come into a room, see them putting it out, and things like that. But one day I ended up talking to them, and they were saying, you know, we've been doing it for so long, you know, we're almost in our 80s. Why should we stop? I mean, what's the benefit? I feel like the damage is already done. And doing some research on this while doing this paper, I ended up finding that that's a general trend for those over the age of 65. And as people get into their older years, there's a lack of thought into benefits. For instance, socially, research has shown that those who quit smoking, even over the age of 65, end up living, for men, up to 2 years longer, and women could be double that. So socially, imagine the impact that you can have on your family on being able to make it to someone's graduation. My grandparents weren't able to make my graduation, but if they were able to stop smoking and see the benefit in that, they could have made my graduation. They could have been to their great-grandchildren's birthday parties. And that's just a personal experience I want to share with y'all, is a lot of people think that there's no benefit to it, not only just physically, but socially. And it not only impacts them, but it impacts everyone around them. And that's just something I wanted to share with everyone as part of our project.
So just a little bit more information about our partner. We partnered with Carteret Health, as Paula said earlier. Carteret Health is a healthcare system that primarily serves patients out in Morehead City on the eastern coast of North Carolina. And I forgot to put the demographics on here, but many of the demographics fit the average North Carolinian demographics. Median household income is in the 30,000s. They do serve primarily 90% white patients, with a higher than average percentage of patients over the age of 65, which was about 25%. And so we, for our project, what we did is we partnered with Brendan Carney. He's a PA. As Paula said, he's been noticing a lot of no-shows at smoking cessation appointments. And we just wanted to know why. And in knowing why, maybe we could offer solutions for that why. And so the goal of our project was we did a quality improvement project where we reached out to patients that Brandon Carney provided to us to just talk about smoking cessation and what smoking cessation did. They had to sign a form to be able to participate, and we called them and asked them a lot of questions. Well, not a lot, but several. These are the questions that we answered. Most of these questions we had them answer on a scale of 1 to 5, with 1 being strongly disagree, 5 being strongly agree, and 3 being somewhere in the middle. That's how I always described it to people on the phone. And patients, some of these questions didn't necessarily apply for reasons that I'll get to shortly, because they might not have gone to a smoking cessation appointment or even made an appointment yet. But as the 7th question is, we just also wanted to hear what they thought about smoking cessation. So that question wasn't necessarily answered on that 5-point scale. So kind of just like the basic results, we actually had, Brandon worked really hard, and he got us 6 patients that we could call, technically 7, but we spoke with 6 patients using Doximity. All of these patients are patients that Brandon either talked about smoking cessation in his clinic or been referred to smoking cessation. But when we actually spoke with them on the phone, at least in my experience, some of them hadn't even made appointments, and some of them weren't even going to make appointments. And so that kind of gets to like the results, like themes of kind of what we heard when we talked to patients. And I have a lot of themes, I'll go through them quickly. But I think the biggest thing for us is that most patients, these were patients Brandon had talked to about smoking cessation, and they knew they were going to talk about smoking cessation with us, but they weren't interested in doing it. They were neutral, or like 1 to 2, like strongly disagree that they have any interest in smoking cessation. And not only that, were they uninterested in smoking cessation, they felt like if they were going to be interested, they could do it on their own. They wouldn't need anyone. I think my favorite quote is that I could do this if I had Chantix, which Chantix we all know is, I think it's Verculene, which I believe has to be prescribed. So they still think they could do it on their own if they, have medication. But other people just had no interest in quitting. It's a lifelong habit, kind of to Logan's point with his grandparents. It was enjoyable for them. And they were also just around people, their families, their spouses, maybe their children smoked. And that made it a very social activity for them. And not only that, it was going to smoking cessations. Many patients talked about how it was time consuming for them, even expensive, because they would have to pay copays in order to go. And with little motivation to quit, why would they go through something that's time consuming and expensive? And if it's not causing them any health problems, then why do it? And if they can do it on their own, again, why do it? So those are just some of the potential themes. And we really enjoyed talking to all these patients. It was a really great experience.
Thanks, Alex. So I'll talk briefly about some of the solutions that we came up with. So first of all, some of the feedback we've heard from patients when we called out to them. So asking a patient what's making it so, what makes it difficult for you to quit? Have you had any attempts in the past? What are triggers that cause you to relapse if you have made previous attempts? And then what do you perceive as the barriers to success? So transportation was a really common one that came up among the patients that we called. I think this is true of any rural setting. Obviously, clinics can be as far as an hour away from somebody's place of living, potentially even farther. Not everyone has access to a vehicle. Some people rely. I know I've worked with patients that rely on family members to transport them. So timing can be an issue. And of course, now with the price of gas, that can also be an incredibly expensive trip for them. Public transportation isn't nearly as good in a very rural setting. So transportation can certainly be an issue. Lack of social support was another one that I heard quite a bit. Of course, if you can imagine trying to quit smoking when you live with a group of people who all smoke and have no intention of quitting, that's going to make it significantly harder. You certainly can't just go and dump the cigarettes in the toilet and out of sight, out of mind if they're surrounding you all the time. And that social support is a big part of quitting. So if you don't have that, that can be a big barrier. Of course, cost and insurance is always going to be an issue in every population. I think it's particularly difficult in rural populations a lot of the times. So looking at the cost of co-pays, looking at the cost of medications, especially for these patients who are going to require frequent visits to the clinic. And I won't go through every single one of these. We'll talk more about stigma on the next slide. Medication non-adherence is a really important one, though, that I think it's worth mentioning. There's a twofold increase in success of smoking cessation when using these medications, including varenicline, bupropion, and nicotine replacement therapy. And in fact, they have some really impressive number needed to treat ratings. The varenicline is an NNT of 6, bupropion is 12, and nicotine replacement therapy is 15. So using them in combination or even choosing one can greatly increase your chances of successfully quitting. But of course, we know that they are expensive, they have side effects, they're easily forgotten. So checking in with patients about their medication adherence is important. We can go to the next slide. So I don't think you can talk about substance use disorders of any kind without at least talking a little bit about motivational interviewing. And I think this comes back to these patients who oftentimes don't feel like they're ready. They're in that pre-contemplative phase. Using motivational interviewing to better understand their motives behind smoking is really important. So there's this helpful mnemonic, ORS. O is for asking open-ended questions. So not asking yes or no questions, not leading them with questions, not asking like why, because that can put them on a bit of a defensive, but really being genuine and asking open-ended questions about what's driving their habits. A for affirmation. So the USPSTF and the AAFP is really big on asking every patient at every clinical encounter, giving them the strong recommendation to quit smoking, and then using positive reinforcement to help them with that quitting rather than negative reinforcement. So talking about the benefits of smoking rather than the detriment of continuing to smoke has shown to be more effective. R is for reflection. So rather than just restating what a patient says, take it to that next level and show them that you understand what they're saying. And then S, just use that conversation to build momentum and evoke change. And this can be particularly helpful in patients. I mentioned stigma. There is a negative stigma around any form of substance use disorder, and that includes smoking, even though it has been around in this country for so long, and it's an ingrained part of our culture in many places. There is a very negative stigma in the healthcare setting. And so using motivational interviewing to ask them open-ended questions and show them that you're interested in who they are can help kind of build that therapeutic relationship, which is, we know, of the utmost importance. And I'll just give one example of a question I like to ask, and that's what positive sort of things does smoking bring to your life? How does it add to your life in a positive way? And then following that up with, how does it bring negative to your life? What negative components does smoking bring to your life? So you give them a chance to reflect on the things that they like about smoking, and then the things, hopefully they have many of the things that it's taking away from their life, including their life. You can go to the next slide. So just a couple of examples of some specific solutions. So telehealth on the bottom left, that's my little telehealth symbol there. That can help with transportation costs. That can help getting patients into the clinic more often. Most everyone now has an iPhone or some kind of a smartphone that they can use for telehealth. So that's a really good solution. The Quitline NC is a really great program that patients can be referred to throughout North Carolina, and there are many like it throughout the country. This program particularly gives access to free nicotine replacement therapy and a coach that can help you quit. So a really good resource. And then I just put this little American Heart Association poster that highlights some of the benefits of smoking. So I like that in 12 weeks, it's easier for your heart to pump blood. I think that's a good way to positively reinforce something that will help motivate your patient to quit. Next slide. And I'll just wrap up by saying this can be a really tough battle. I know I just spoke with Brandon about this with patients who don't feel like they need to quit and maybe won't feel that way until they have a medical complication. And I think it's just important to recognize that this is going to be a battle. There was a 2005 study that looked at about 1,000 patients that said the average number of attempts before successfully quitting smoking was 30, which is a massive number. So recognizing that relapses are not failures, but they're just kind of a normal part of the process can help us reduce, fatigue and help the patient reduce that feeling of futility and failure as well. And just we can go to the references here. I'd just like to thank Dr. Clyde Brooks, who got us in contact with the amazing PA, Dr. Brandon Carney, who took some time out of his busy clinic schedule to get us these patients to call, and that was really helpful. So thank you, and thank you to the FCLC team as well.
Fantastic. Kudos. Thank you all. Great presentation and so much to think about. I did see that Brandon Carney, Mr. Carney is on, and Brandon, you were so helpful to this group. We really appreciate your engagement. I don't know if you have any thoughts to share hearing the group's presentation or other questions for this group.
I think my microphone is working. I think they did an excellent job. It was unfortunate that we didn't get more patients to participate. A lot of people were reluctant to help out, which was kind of shocking. But great presentation.
Yeah, thanks so much. It's such a there's so much stigma just around the word smoking cessation, and so I think that came up a number of times. Sarah, I don't know if your hand was up. You had a question for the group.
Yeah, I was just gonna ask if you were able to implement anything that passed your final slide, or whose job that would be. Like, how do you envision those things are all great. How do you envision those suggestions rolling out and staying sustainable? Is that a person in the clinic? Who would that be?
I think that's an excellent question. So our solutions were like pretty broad because our focus was just trying to figure out why people weren't coming to smoking cessation appointments. This is a nationwide problem, getting people to quit smoking. So we really just wanted to be able to provide Brandon with some background that maybe he wouldn't have had a chance to be able to gather in a busy clinic, to be able to say, maybe this is why people aren't like showing up to their appointments. So it wasn't necessary. Like, I know a lot of our colleagues have come up with like very like concrete, like tangible solutions, but our solutions are just these themes about talking. These are, again, like I said, but these are all patients who knew we were going to talk to them about smoking cessation. And I think it was just very surprising to me how so many of them just said they weren't that interested. And if these are people who maybe Brandon is trying to get into clinic and they're not interested, I can understand why they just wouldn't even show up. So maybe that's really the point of the project.
Yeah, thanks, Alex. Dr. Greenblatt.
A terrific presentation. Another super challenging topic in healthcare, and I'm really glad that you guys touched on motivational interviewing, because I agree it's super important. I was really struck, Alexander, with what you talked about when you interviewed the patients about their own thoughts and feelings about their smoking, and their interest level in quitting was awfully low. And I'm wondering, is there something that would make sense as an intervention, maybe for the providers who are referring these patients, so that maybe upstream they engage with the patient some, maybe get some ideas going around, and so that by the time the patient gets, like set up for this appointment, they've at least, I don't know, maybe some MI is happening where they're starting to think about their own reasons for wanting to quit. Anything that could be done to try to improve that motivation at the point of intervention?
I do think it would be interesting to ask several patients to talk about family situations in which their like spouses and parents smoked. And so then you get them away from the healthcare system where they're back in a smoking environment, and maybe just like getting a little bit about like, oh, are you around people who smoke, and maybe that will inform their choices. I don't really have any specific solutions. I don't know if anyone else in my group does. Maybe even just like trying to implement some of these questions that we asked, in just like a very straight, like forward tone. I don't know if this could be like a survey that could be sent. I mean, it's not verified or anything. It's not reliable, but we did get a lot of like similar answers when we talked to patients.
Yeah, and I could just add to that a little bit, Dr. Greenblatt. Thank you for your question. What I've found, so in this particular healthcare system, I'm sure this is very common among many others, but a lot of the patients that Brandon was seeing were referred from pulmonology. So they're already having many of them are already having some existing lung issues. So what I found, working like with a different population with diabetes, is using motivational interviewing to find out what are they concerned about, like what is their motivation for controlling their blood sugar. So it may be kidney disease. Maybe they saw a loved one go through severe kidney disease and had to be on dialysis, and that is what is motivating them to be so strict with their blood sugar control. If maybe the referring provider could take the time to parcel out, like, what is the thing that's driving you to want to quit smoking, if there is anything, or help to build that. I think that would be helpful. It would give them a reason to at least go to the appointment and learn a little bit more about the options.
Great comments. Thank you, Alex and Austin. Dr. Coppola.
Yes, again, another excellent topic. And I think a lot of where the science of medicine meets the art of medicine is doing what you talked about, figuring out what's important to the patient. And there's often a disconnect between what's important to the clinician and what's important to the patient, not only about smoking, but other behavioral change. So your patient may not be thinking about the cancer or the heart disease with smoking, but if it's a young parent, well, do you know having a smoker in the house increases the risk for sudden infant death syndrome? That may be the important thing that, really drives home to that patient. Or financial. I tell patients regularly, if you want to save money, stop smoking and use nicotine patches. It's half the cost. And that may be important to people. But there are data. I'm glad you got into the numbers needed to treat for the different smoking cessation interventions. One more to add to that, just being who you are as a physician or a physician assistant, healthcare professional, telling a patient to quit has a number needed to treat of 20 by some data. So keep at it. So if you have a panel of 1,000 patients who smoke, you can get 50 patients to stop smoking eventually. So keep at it. Don't lose heart.
Great comments. Yeah, it's so interesting. We implemented a smoking cessation clinic in our cancer center a while back, and I think there was less lead-in from the referring provider when there was a dedicated clinic than when that dedicated clinic didn't exist, because it was sort of just that's what the clinic is going to do. So a very good point that the intervention starts before the referral goes in. Wouldn't you just love it if Epic sent you, a message as you were putting in that referral, hey, did you know by, quitting smoking, your heart will pump 30 times more, in 12 weeks, or, you'll save $2 a week or something like this that you could relay to the patient. Great ideas. Well, thank you, group. Great presentation and a lot to think about. Tough problems. So you've left us thinking about that. A lot of insights. We have one more group, and our last group is going to shift us gears a little bit. Partnered with Scott Paviel's Paviel Dermatology practice, and so we'll turn it over to you.
Hi, everyone. I'm Dr. Smale Waldrop, and I am going to be presenting on behalf of my team Lilies, but I will give them a moment to introduce themselves.
I'm Tamrich. I'm a fourth year at Wake Forest.
Hi, I'm Sammy. I'm a PA student at Duke.
Hi, I'm Tyra. I'm a PhD graduate from UNC Chapel Hill School of Nursing.
Okay, so we're actually going to go kind of full circle and go back to kind of what Team Daffodils, one of the questions that they had earlier was about health literacy. And so kind of our whole project is on health literacy, but more specifically for like pre-appointment health education and then post-appointment like reminders and things like that. So we met with Dr. Pavial, and he is a dermatologist in Charlotte, North Carolina. And we were talking with him about, kind of where we wanted to take our project. And he had mentioned to us that a lot of times patients will ask very similar questions that are kind of eating up the time that he has to talk to them about their like personalized questions regarding their skincare and their healthcare. And so we wanted to kind of address, well, how can we kind of eliminate some of those more basic questions so that when they are in the appointment, they can focus more on individualized questions or individualized concerns to kind of help the appointment go more into like more complicated understanding of their treatment plans. So our next question was kind of, how are we going to implement that in a setting outside of the actual clinic? Because, you only have, 15 minutes to 20-minute slots with each patient. So you want to utilize that time as best as you can. So he has a really beautiful website. He's done a really great job with his website. So one of our kind of our first tools was using that to help us out. So just for some background and some statistics. So health literacy, by definition, is people's ability to obtain, process, communicate, and understand basic health information and services. So during our research, we kind of discovered that very low percentage, 12% of Americans have the skills needed to actually be considered health literate. And of course, that does put them at risks for a lot of different things, including medication errors. It kind of prevents them from advocating for themselves. And it also can kind of prevent them from having the discernment to know whether something is an emergency or, whether something can wait till that follow-up appointment in 4 to 6 weeks. So one of the interventions is to kind of create a education that is easy to understand, is kind of like not necessarily elementary, but is accessible to everyone and everyone's learning styles. So, visually, auditory, things of that nature. So that kind of leads us to where we go from there. So again, we kind of talked about how when you're at a lower health literacy, you do have a lot of questions during your appointment that could be answered prior to that. And so, again, like we were saying, to have more productive in-clinic face-to-face time, you want to provide them with resources prior to them stepping into your clinic and stepping into their appointment. Also, it's kind of thought that if you provide them a lot of information before their appointment, it does kind of quell that anxiety of their appointment. And sometimes I think that that gives the patients a lot of confidence. So when they come in, they kind of know what to expect. And I think that can also just build a better relationship with the patient. And then, overall, we want to provide patients empowerment, and we do want them to be able to advocate for themselves and to ask questions that are more pertinent to their lives specifically, and kind of give them more time to ask, or talk about concerns that relate to, things that they're like, well, I read this on the internet, and so I'm kind of nervous about taking this medication that you think would work for me. It's able to actually get to the nitty gritty of that conversation instead of them kind of you giving them the medication or the treatment plan, and then they go home and they research it and they're like, oh, I don't know if this, if this is really the best plan for me. So kind of gets rid of that as well. So for our project, we identified key topics that could use some improved health literacy. So we picked acne, we picked like what to expect from a skin biopsy. We talked about like what is a skin check. So there's about, I think we had 9 total topics that covered things that Dr. Pavial sees pretty, on a daily basis. So, and then we developed 4 or 5 common questions that patients ask about that topic just across the board. And then we met with him at his practice in Charlotte, and we actually recorded videos of him discussing each topic. Once we got those videos, we then took that information and put them into like a written education. So that written education includes graphs, graphics, and then just kind of simple, more bulleted points just to make it easy to kind of digest. And again, kind of not necessarily elementary in subject, but just concise and kind of easy to retain. And then of course we provided these materials to him so that patients can go on his website and access this before their appointment. And then also something that we discussed is having like an option for after their appointment. There's a link that they could click and it would have all of that information that they talked about in their appointment, kind of similar to my chart, but it would kind of help them with like when they're supposed to come in for the next visit to kind of eliminate those calls to, you know, his staff about, oh wait, did I have a follow-up appointment or when that was? So that's kind of the skeleton of our project. So again, I kind of already talked about our solutions, but health literacy, I think, is never not an easy thing to resolve, because I think, especially when you have an area like Charlotte that has kind of a large socioeconomic and diverse patient background, you know, you can't always assume that your patients have even a basic understanding, even if they do have like a higher level of education. So I think that makes it difficult to fully like solve the health literacy problem. But we're kind of hoping that the videos and the written prompts will kind of bridge that gap. And then with some of the research that we found, I have here like little charts of like ways that you can improve health literacy through spoken communication, which we did again try to implement in the videos. So, you know, you always want to greet the patient warmly. You want to make them feel like, you know, you want them there and you're happy that you're there. And then, you know, you always want to use plain language and slow down. And then my personal favorite method that I learned in medical school was the teach back method. And, you know, that's where you present information to a patient and then you actually ask them like, oh, okay, well, you know, can you tell me what you're going to do with this medication when you get home? Or can you tell me kind of what we talked about today? And I think that's a great way to gauge like what did they retain and what did they not retain? So you can kind of, you know, go over the stuff there. And then for written communication, again, the biggest thing is that it did kind of say to stick to really simple graphs, use really nice graphics, use bulleted points, clear, concise language, because, you know, even I sometimes if I get like a handout and it's like 5 paragraphs with like the, you know, 10 font, it's hard to keep my attention for that long. So those are just some basic principles. And then again, the 4 key areas that can be improved through health literacy includes the spoken communication, like we just talked about, the written communication. And then this is the one that I think is really important and really special to me is the self-management and empowerment component. I think, you know, really if you do give that patient the sense of being able to log in before their appointment and like take the initiative to have all the information that they need specifically from their physician, it does give them the confidence to come in, and it does give them the ability to ask questions without fear of being like, oh, I think this is like too basic of a question to ask, or I think this is like too common of a question to ask. And I think it really does build a good rapport. And then of course, supportive systems as well, which again goes back to that like patient, you know, doctor, patient, healthcare provider interaction where, you know, they really do feel like they can trust you and they're able to get their needs met. So in conclusion, some of our long-term goals with this project is that Dr. Pavial can kind of continue to use this format throughout his practice, and he can adjust information, adjust content, add content as he sees fit. Is a pretty simply designed project. So we're hoping that it's able to continue to be replicated. And then again, most importantly, is just providing patient empowerment. So it's about being able to give the patient the ability to advocate for themselves, educate themselves, and then ultimately feel confident in their encounter. And then if we have time, I can hand it over to my colleague who can actually show you guys one of the videos that we took, but only if we have time.
We have time. Let's see it. That'd be great.
If you stop sharing, I'll be able to share mine.
Okay, great.
So here's one of the videos. Can you all see that I'm about to press play here?
We can see it.
Perfect. I'm going to let Dr. Pavial speak for himself in this video format.
What is a skin check? So a skin check is where you come into the office and we look over for your entirety of your skin to see if there's anything on you that we're worried about. We also want to make sure that you get a better idea of what to look for in uniformness, because you look at your skin every day. And then we also want to get a schedule for how often you should get your skin checked based on your risk factors. When you come in, we'll take your medical history and then have you get into a gown. We look all over and make sure that everything's good and you're about your way.
And so along with each of the videos, let's see. Are you guys able to see that as well?
We can see it.
Exactly. So along with each of the videos, we have a corresponding sort of written document that is just essentially a transcription of what he's saying, sort of simplified and just in sort of a word format, simple to read, doesn't take up too much time or space, and just also provides. That's just one example, but as we sort of talked about in the presentation, we have several of these that sort of Dr. Pavial will be able to update or sort of change depending on his practice types. Like we talked about acne, filler, pre-appointments, post-appointments, and essentially overall just give him flexibility over time to change these as he sort of needs to, depending on his patient needs.
Fantastic.
With that being said, any questions?
Great job, team. Savannah, Cameron, team, thank you so much for the great presentation. We have a little bit of time for questions for this group, so we'll open this up for questions. Dr. Greenblatt, yes. You're muted.
I'm trying to make it so you guys don't have to hear my dog while you're presenting. Then you don't have to hear me when I'm asking questions either. That's a really nice presentation, and again, a very important topic. I'm wondering, did you come across any information about the relative effectiveness of giving people information via video format versus print? I would have to imagine in our so video-oriented age that people like to look at a video rather than have to read something. Do you know anything about that? And should we be shifting in one direction or the other, or a combination? Is that the best way to go?
Yeah, I can jump in. So I think you're right with the video sort of education materials are probably what most people prefer, I think, in this day and age. But I think the best sort of option or solution is to have both, in case there are those individuals who don't have, I don't know, like a computer or a smartphone or something like that, that they can't access multimedia sort of visuals. So I think the written aspect nicely complements the visual aspect. So I think a combo of both would be best for the future, just to give different options for different people and their needs.
Great comment. Any other questions or comments for this group? All right, we're getting a little bit late into time, and so I think great presentations, great discussion. It is, Savannah, you brought up the importance of that trust piece and rapport that just happens even through patient communication. And you were able to see that a little bit with Dr. Paviol's video, which is a really important point there as well. So great presentation. All the groups, I would like to thank and just congratulate all of 5 of our groups for phenomenal work. Again, these are students who are in school doing work in clinical rotations, you know, and all the while then on their free time. And we know everyone has a lot of that, partnering with these 5 practices to do some really phenomenal work. So students, congratulations. It was fantastic to hear from you. To the 5 practices and health systems, thank you so much for partnering with our program and with these students. It was clear how engaged each of you and your practices and health systems were. It was just phenomenal. So thank you so much. And to everyone who joined us, it's great to see you again. Many of you I haven't seen in a while, so it was great to have you join. We really appreciate your engagement with the program. And so thank you for coming and sharing your expertise and insights with our students. With that, I will turn it over to Tina and Aisha to see if there are any final comments from their side, and then we will close.
Well, just thanking everybody. I just want to piggyback on what Dr. Star is saying. Thank you to everybody who's here tonight. This is such an impressive group because I completely wholeheartedly agree. Being in school and finding time for this program just shows, that in itself just shows the leaders you are already and the future leaders that you will be in the profession you have chosen. So I just want to applaud you for that, because it is always a joy to work with you. And personally, I think that we all learn so much from your projects, your angles, what you look at, how you speak with people, what you pick up. It's always so inspiring. So I can't thank you enough for all the efforts and the work you put in there. And to Dr. Starr's point as well, thank you to the practices that have been working with you as well for being there for you. So I feel very hopeful for the future with you as incoming health professionals or already health professionals and leaders in healthcare. So thank you so much for that.